The medical directors of all 5 hospitals realise that many of their services are beginning to crack. As consultants retire, they are replaced by more than one. There are some specialties where we can't recruit consultants because there just aren't enough in the country. There are junior doctors that we can't recruit because they either don't want to go into a service or because there aren't enough of them around to meet the European Working Time Directive. So we've known for a long time as medical directors between us that we have to start working together. What this programme does is it allows us clinically as doctors, nurses, midwives, clinicians to develop a solution to the medical problems of South East Midlands, and we're working then with the commissioners, the managers, to create hospitals, 5 hospitals that are sustainable both clinically and financially to keep the government happy for the next 10 years at least. My vision for this programme is that the majority of patients will continue to get the majority of their care either at their local hospital or, more importantly, closer to home in either a GP surgery or a dedicated community clinic of some description. In exchange for that, some of the specialist services will have to move. We'll have to bring them together on less than 5 sites at less than 5 of the hospitals so that we can create high quality teams of doctors and nurses to deliver the best possible care and 21st century standards for the population of South East Midlands. Let me give you an example why things have to change. Recently, a very good friend of mine, a consultant surgeon, retired. Good luck to him, that's what I say. But he was an old-fashioned consultant general surgeon. When he started, he did everything. When he retired, he had been replaced by a consultant vascular surgeon, a consultant breast surgeon, and a consultant gut surgeon. 3 consultants, highly specialised to deliver what one man could do 25 years ago. The health service can't go on like that. The only way the 5 hospitals can keep working is if we bring those skills together to create high quality teams. Take obstetrics, for example. I'm an obstetrician. I know that the care we provide on labour ward, it's the most crucial time in a baby's life and in the parents' lives as that baby is delivered safely and happily into this world. If we deliver that supervised and led by consultants, not by junior doctors in training as has been the case for years, but by consultants, we know we will get better outcomes. So if we produce 3 consultant-led obstetric units of high quality with consultants present on the labour ward 96 hours out of every week, that's almost every hour during the day and only a few nighttime hours when they're not there. They will supervise, they will train, and they will ensure that babies and mothers are safe throughout childbirth. And if you're safe in childbirth, you need a good quality paediatric service to look after you as a child. So if we get our services right for children, most of them should not be in hospital. They should be looked after in the community. We don't want them in hospital, but when they're really ill and they need to be in hospital, we need high quality teams to look after them. Across the South East Midlands, with a population of 1.6 million and rising, we know that there won't be enough inpatient children to sustain 5 units. So when it comes to paediatrics, why is the working group suggesting that we only have 3 inpatient paediatric services? Well, the reason behind this is because there aren't going to be enough sufficiently sick children to warrant 5 if we get the out-of-hospital care and pathways right. Children should not be in hospital unless they're very, very sick. So what the Children's Working Group is proposing is 3 inpatient units supported by outpatients and short stay assessment units on the other sites to deliver the highest quality care and maximise the use and the skills of the clinicians that they have. When it comes to surgery, we have to be completely logical. There is very clear evidence that for elective and complex surgery, concentrating onto a smaller number of sites so that we develop the skills not only of the surgeons but also of the teams creates and delivers a better quality service and outcome for patients. But if your surgical teams are concentrated for elective work onto 3 sites, It's very difficult for them to spread themselves more thinly for the urgent work. So for emergency surgery, what we are suggesting is that we have those teams concentrated around 3 sites to support the A&E departments, so that when you are really sick and need a surgeon, everybody knows where you will need to go for the best possible care. So what do we mean in the proposals, in the models, when we say networked A&E? Well, at the moment, every A&E department delivers most things. Even now, not every A&E department delivers everything in terms of emergency care. What we are suggesting is that we create 3 high-quality A&E departments that will deliver the vast majority of urgent care as and when you need it immediately. And we've looked at the travel time. If you're in an ambulance from your home, it's only going to add a matter of minutes to go to the right place compared to a lot longer if you go to the wrong place. But that means that the other sites will have a networked A&E. What a networked A&E is an A&E department that will still see patients as they walk in off the streets. It will still see patients who've had accidents and come along, and what they will do is they will work to clear protocols, they will work to clear guidance, and they will know exactly how to deal with you, so that they are dealing with you in exactly the same way as the big A&E down the road. And they will have properly trained staff who've gone through clear training programs to deliver that best quality care for you. But sometimes it will be better for you not to go there, and under those circumstances the ambulance won't take you. But don't forget, that already happens. If you're having a stroke or a heart attack, you will already drive past an A&E department that is inappropriate to go to one that is appropriate. That's already happening. So what do we mean by networking? Networking is hospitals working together to create a high quality service. As an example, let's look at vascular surgery in the southern half of the South East Midlands. 10 or 12 years ago, my father-in-law had a rupture in the main blood vessel coming out of his heart. He lived in Ireland. So I, on behalf of my wife, rang my colleague who was a vascular surgeon and said, what are his chances, because she's trying to get over to Ireland? And he said to me that 10% get into theatre. And of those 10% that get into theatre at the moment, 10% of them come out of it alive. That's 1% survival. 10 years ago, we started working in Bedford with Luton and Dunstable Hospital to create a vascular service for Bedfordshire and Luton. Outpatients is done in Luton. Day surgery is done in Luton. But if you have an emergency and that vessel goes and you go to the A&E department in Luton and Dunstable Hospital, they will put you in an ambulance with the blood that they've been cross-matching while they tried to sort you out, and you will come to Bedford Hospital A&E. But you won't stop there, because as soon as they knew you were in Luton, they rang us and our surgeons came in, and they will be waiting with the anaesthetist and the team in theatre, and you will go straight through A&E, straight into theatre, and we will operate on you immediately. That has meant that we now have been able to reduce the mortality to less than 10% for when that blood vessel goes. And in terms of networking, we've now included Milton Keynes. So as of last year, Milton Keynes patients will also go to Bedford if their blood vessel goes. But the Milton Keynes surgeons, and there are only 2 of them, couldn't do that on their own. So they work with our surgeons and the clinical team of nurses and staff in Bedford to make sure that you are safe. Why do we want to have a networked A&E? Well, we know that if you network and work to clear protocols so that everyone is getting the same treatment, your overall treatment will be better. You don't want to go to one A&E department and get one sort of treatment and another A&E department and get another. You don't want to be transferred and be told they got it wrong. So what's important is that everybody works to the same standards, the same protocols and the same high quality, so that wherever you go in the area, you will be looked after in exactly the same way, and your care will be the best it possibly can. And that means by whatever staff we have, whether it's consultants, super trained nurses, super trained GPs, junior doctors, they will all work to the same standards.